Hi, this is Ahmed Khattab, and this is the first of 3 videos about pacemaker basics I intend to make. The layout of the video is very simple. It's divided into 3 different sections, each lasting anywhere between 15 to 20 minutes, followed by a quiz. In this video, we will talk about what is a pacemaker and the different types of pacemakers. We will also talk about the fundamentals of how does it work. Then we will discuss how can it be used to treat different heart conditions and how to select the appropriate device accordingly. Ready? There we go. As you can see in the initial picture, and as I think you're all aware, this is the pacemaker generator or the pacemaker can. This bit is called the pacemaker header, and this is where the leads rest. So the leads are basically enabling to send and receive electrical signals to and from the heart. So next we're going to have a look at the pacemaker. How does it look like in a chest x-ray? So this is basically the chest x-ray, and as you can see over there again, this is the generator or the can. This is the header, and here are 2 leads attached to it. So that makes it dual chamber pacemaker. One of the leads, if you follow it, goes all the way to the atria. The second lead goes all the way to the ventricle. So atrial lead and ventricular lead. As you can notice over there, there is some slack over there, which is important to allow slight movement of the pacemaker without the leads being dislodged. The next thing we're going to have a look at is the heart structure and the conduction system. So this is the heart structure. This is a very crude diagram, but I think it will do the purpose. This is the right atrium. This is the right ventricle, and this is the tricuspid valve. And again, on the next side on the left is the left atrium, left ventricle, and the mitral valve. Superior vena cava and inferior vena cava. If we add the conduction system to it, this is something you're going to get like that. So it's the SA node, where in a normal heart, electrical signals should start from there, goes all the way to both atriums, makes it both contract, and then it goes to the AV node, which is the gatekeeper between the atrium and the ventricle. Below the AV node is the bundle of Hess, which divides into right bundle branch, which goes all the way over there, and a left bundle branch, which it divides to left anterior fascicle and left posterior fascicle. So now we have an idea about how does the pacemaker looks like and the conduction system of the heart. Let's find out what does the pacemaker exactly do. So pacemaker in short is basically used to treat conduction heart problems. Conduction heart problems can happen anywhere in the conduction system. So if it can happen from SA node, it can happen from there if you choose to select this bit over there, which is the heart, the SA node. So SA node problem. To start first, we're going to have a look at the normal ECG, or how a beautiful normally looking ECG should look like. This is a P wave, PR interval, QRS, and then a T wave. Right, so the P wave is basically the SA node causing the atrial to contract, and then this is caused by the PR interval. The PR interval is caused by the AV node, and then the QRS complex is caused by ventricular depolarization. And then this bit is the T wave, which is caused by ventricular repolarization. This is in a completely normal heart, but let's look now at the ECG below. If you look at the ECG below, this is again a P wave, QRS complex, T wave, another P wave, QRS complex, T wave, P wave, and then nothing. So the trouble that happens in the SA node can be in the form of sinus pose. We'll speak about each troubles in more details and how does the pacemaker help to fix these troubles. But now I'm just giving examples of where, if something happens along the conduction system, what are the possible outcome of it. Next, we can have a look at the conduction system and if some trouble happens in the AV node. Sorry about that. Right, so Right, so if a trouble happens over there in the AV node or just below it to the bundle of Hess, can cause heart block. Again, if you notice over there, SA node sends signals, so because the SA node is normal, and another, and nothing goes through. Why? Because basically the AV node is being malfunctioning. And then there's another like escape beat which happens over there that manages to escape from the disease area, and it looks like something like this. And this is known as complete heart block. The third example that we're going to speak about, what if the trouble happens in one of the bundles? So let's have a look over there and let's assume that SA node is normal. So if we assume the SA node is normal, AV node is normal, but let's assume there is a trouble in there in the left bundle. So the third thing that can happen is this synchronization of the ventricles, of ventricular beats. How does this happen? So imagine if the impulse or the signal goes all the way from the SA node to the AV node, bundle of Hess, and then it's supposed to be divided into the right bundle branch and the left bundle branch at the same time. Right bundle branch, it goes all the way nicely, left bundle branch, it gets blocked. That means that the right heart is going to beat not in synchrony with the left heart. So, which means desynchronization equals less efficient heart beat, which means less blood pumped, which equals symptoms. The symptoms can range anywhere between shortness of breath, lightheadedness, or even fainting. So, to give you an example of what exactly the pacemaker do, we're going to go back to the example of the SA node problem as a quick example of the function of the pacemaker. There we go. We will speak a little bit later on about in details of what exactly the pacemaker is capable of, but let's see it as a very simple example over there. If we have a malfunctioning SA node, we can just insert a pacemaker lead over there, goes all the way to superior vena cava, and then it goes into the right atrium somewhere over there, and this is the pacemaker box. Right, so if the pacemaker is basically, this is what's happening, there's a sinus pose, it's going to be able to sense that there's nothing happening in there. So it's able to sense that the SA node is not beating anymore, and then it will tell the heart, send it an outpost pulse, tell the heart you have to beat, and then the heart beats, and then again, and then it sends another impulse, and then the heart has to beat again, and so on. So this is how it keeps the heart beating and avoids any of the symptoms. Now let's clear the board and have a look at the different types of the pacemakers available. So just over there. Right, so different types of pacemakers. If we go to that bit. Types of pacemakers. Right, so the first type is single chamber pacemaker, which means there's only one lead. This lead can go to the atria, as we have seen in the SA node problem, or can go to the ventricle. We will explain later on. And then we have a dual chamber, which means two leads that goes to both atria and the ventricle. And then we have the last type, which is biventricular, which means it goes to both ventricles. Right, so let's have again a quick look about the axis obtained for the pacemaker and the leads. So this is basically the heart again, And now I'm going to be continuing the drawing of over there. If we go over there a bit, so the colors are not going to be exactly the same, but you need to imagine a little bit. So this is the cephalic vein over there, the one I'm pointing at. This is the axillary vein, the big one over there. They join together to form the subclavian vein. And somewhere in there, let's assume it's over there, it's going to be the internal jugular artery, internal jugular vein. So axis can be basically obtained from the cephalic vein, subclavian vein, and very rarely from the internal jugular. So when you put the axis in there, or you can actually put the lead in there, that means that the lead, let's assume it goes from the cephalic, goes all the way from there, from the through this through the subclavian, and from the subclavian it goes all the way to superior vena cava, and then it goes to the right atrium, and this is the atrial lead. Same again happens if it goes to the ventricle. If we're going to talk about the ventricle, it goes all the way, passes through the tricuspid valve, goes to the right apex over there. This is the, now we have a dual chamber if we have two leads over there. So if we have two leads over there, that means basically one in the atria, one in the ventricle. The third, when we want to insert a third one in the ventricle, so think about it for 5 seconds. How can we insert something in the third ventricle? In the second ventricle. So the option is basically either to perforate the atrium and goes all the way, let's assume it's going to go all the way over there to over there, or we can perforate the ventricle to go again over there. But these options are not really the best because it will induce myocardial injury. So the option that's mostly done all the time is go through the venous system. So let's assume that this is the coronary sinus, and this, it goes all the way from the back of the heart, and then it's wedged in front of the heart. So now we have 3 leads in the heart. If you think of the functionality of the pacemaker, it's basically like a TV. You have the option of getting standard TV. You can also have the option of getting the standard TV and a DVD player. And you can also get to have the standard TV, DVD player, plus stereo system. So, more hardware equals more functionality. Same goes with the pacemaker. More leads equals more functionality. Now we're going to talk about sinus node dysfunction and pacemakers. So, faulty sinus nodes can result into different heart rhythms, which could be fast, too slow, pauses, or combination of both. We've mentioned in here the sinus pauses before, as you noticed from the previous 5 seconds ago, and this is the sinus bradycardia, which is basically slow heart rate. I've already replaced the heart with the diagram that I'm drawing. This is basically the SA node, which is being circled over there. We know that from previous that we've mentioned that we can use a single chamber atrial pacemaker, and the reason for that is easy. If the SA node doesn't work, the lead is going to sense it and send it to the generator, say like, hey, the SA node is not working anymore, and then they're going to start sending outpost pulse, and then atrial weave, and then the heart contracts, and then again another sinus outpost pulse, and then the heart keeps beating. However, we tend not to use single chamber atrial pacemaker. We use dual chamber pacemaker. Any idea why do we use dual chamber pacemaker? So the reason for using dual chamber pacemaker is SA node and AV node, they're not very dissimilar morphology between both of them. So SA node disease can preempt AV node disease. So we use dual chamber pacemaker just as a preemptive measure before we go into complete heart block. Now we're going to speak about heart block and pacemaker. So basically heart block is a spectrum of disorders. It could range anywhere between first degree heart block to complete heart block. Pacemakers are usually used in morbid type 2 and complete heart block. So in a complete heart block, you know that the SA node is absolutely fine. The error is going to be somewhere, or the faulty bit is going to be this bit, which is going to be AV node or maybe the tissue below it directly in the His bundle. So I'm going to give you a second to think of which kind of pacemaker should we use. Can we use an atrial lead, single chamber atrial lead pacemaker? The answer is no, we can't, because as we said initially, the problem is in here. So even if we have an atrial lead in here, the signals are not going to be conducted anyways. Can we use a ventricular lead? The answer is yes, we can. So let's see over there. And this is a single chamber ventricular lead pacemaker. Right. So I'm going to mention few troubles or few problems that can happen if you use a single chamber ventricular lead in complete heart blocks. So let's have a look again over there. This is complete heart block picture. This is escape beat. Right, so if we have, let's assume that we now have a ventricular pacemaker. Yeah, it's going to take slightly some time to draw these things. Notice that I've been ignoring the T-wave in these images just to make it easier to understand, that's all. Except in the last bit. So have a look at the second ECG. So the first ECG, as you can know over there, is a complete heart block. And what's good in this ECG? So the good thing about this ECG, we have regular ventricular beats, let's say at around 60 beats per minute. This will keep the person alive because he will get whatever he needs from the heart supply. But there is three problems that can really happen if you notice the relationship between the atria and the ventricle in this ECG. First, if you have no atrial contraction, that means there's no atrial kick. That means loss of the extra filling, which means inefficient heartbeat. And if the atria and the ventricle contract at the same time, because as you know that the SA node is still acting, is still working, then this against they will work, both of them will contract against the closed valve, and the patient will feel that. Besides, having a fixed, which is let's say 60 beats per minute, will not allow the patient to exercise, because the heart rate would remain the same even if he exercises or she exercises. That means poor exercise tolerance, and that again in turn means poor quality of life. So what we use at this stage, still we use dual chamber pacemaker. So this is the second lead, goes all the way as usual. Sorry, that should go in the atria. Ignore this last bit. Right, so we have now atrial lead and ventricular lead. And the beauty of that is, because now we have two leads, the pacemaker can use these beautiful P waves that happens in there as a source of information. So if the patient, if the patient increases the heart rate, then we have much better exercise tolerance in this stage. Next, we're talking about heart failures and pacemaker. So we're going to have to start first by three different definitions that sometimes can get confused. The first one is heart failure. What exactly is a heart failure? So heart failure is defined as a clinical syndrome characterized by signs and symptoms of decreased cardiac output, which means decreased tissue perfusion, and or signs of increased fluid overload. The next thing is cardiomyopathy. Cardiomyopathy is a pathological diagnosis, so it's basically a pathology. The formal definition of cardiomyopathy is a disease of the heart muscle in absence of coronary artery disease, hypertension, and valvular heart diseases. But in the clinical terms, it's mostly used as ischemic cardiomyopathy and non-ischemic cardiomyopathy. Ischemic cardiomyopathy means it's related to the coronary artery disease secondary to ischemia, which is not entirely accurate. The third thing is left ventricular systolic dysfunction. So left ventricular systolic dysfunction is basically just an echo finding. Why is that important? I'm going to show you in a second. So if you look over there, this is the heart failure, and this is the cardiomyopathy, and then this is the decreased ejection systolic function. So as you can see from there, that these can all coexist at the same time, but not necessarily. For example, you can find some people with heart failure but a normal systolic function. So there's 7 different possibilities with these things. Now, moving forward, what is the pacemaker used for in the cases of heart failure? We mentioned when there's this synchronization between both ventricles in the event of bundle branch block. So the basic criteria, which is not entirely accurate at the moment, that I want you to remember for using the biventricular pacemaker, is QRS duration equal or more than 120 milliseconds and ejection fraction less than 35. Okay, so why again do we use the pacemaker in such patients in the first place? So I'll show you a very simple example. This is a bottle of water, right? If you give it a bang from this side, some of the water will come out. If you give it a bang from the other side, some of the water will come from that side. But if you bang it from both sides at the same time, lots of the water is coming out. So it's exactly the same principle that happens with the heart. If you give it stimulus from the both sides, both beating at synchronized beat at the same time, more cardiac output and much more improvement of the heart failure symptoms. You have to remember that biventricular pacing needs to be as close as 100% pacing most of the time. Next, we're going to talk about the cardio-inhibitory syncopes and the pacemakers. Cardio-inhibitory syncope basically means there's fainting in response to an external trigger. So the external trigger could be anything from dehydration, trauma, pain, hunger. There's an extensive and long list of it. So what happens after we respond to the external trigger is basically a vagal response. And the vagal response, which means there is decrease in the sympathetic system and increasing in the parasympathetic system. An outcome of that is going to be drop in the blood pressure, drop in the heart rate, or both. Right, so how can the pacemaker help? So the pacemaker helps, first of all, by detection of when the cardio-inhibitory syncope is about to happen. And this needs specialized algorithms. So this is not a feature in all the pacemakers. So you need to, before you insert a pacemaker for someone with a cardio-inhibitory syncope, you need to make sure that they have the specialized algorithm in there. The specialized algorithm can be using by rate drop, which means they detect if there's a drop in the heart rate before the cardio-inhibitory syncope. The other thing is impedance changes. Impedance changes will be explained later on in details, but impedance basically is the resistance to the electricity in the circuit. So if there's any change in the electricity in the circuit, these pacemakers are able to detect the changes in the contractility of the heart. If it becomes less contractile, that means it's more likely to have a syncope at this stage. And the second thing after detecting it is to deliver the therapy. So to deliver the therapy, what happens next is basically you have to remember that the cardiac output equals stroke volume multiplied by the heart rate. So what does the pacemaker do to combat the decrease in the blood pressure is increase the heart rate for about 2 minutes to a rate of around 100 beats per minute. This ensures increased blood supply to the brain and thus avoiding the syncope. The pacemaker of choice in these cases are usually dual chamber pacemaker. So again, this is the heart, and this is basically we're going to insert the atrial and the ventricular leads. So the atrial lead is important to get information of when is there a syncope about to happen. Also, the ventricular lead is important because the AV nodes can be sluggish during the syncope. So this is why we need to have both leads. And also having an atrial lead allows for the extra kick from the atrium, which increases the perfusion and thus preventing the cardioinhibitory syncope. So this is basically a summary of the conditions that we have in the heart conduction system and the pacemaker of choice. So as we say, the paroxysmal atrial fibrillation, the preferable choice is dual pacemaker, because as we know that paroxysms means sometimes it's going to be normal, sometimes it's going to be in atrial fibrillation. And then we go to the permanent atrial fibrillation. The pacemaker of choice is single chamber ventricular lead, and we cannot use the atrial lead because basically there is chaos going on in the atria. Sinus node dysfunction, you can use single lead atrial, but the preferable one of choice is again the dual chamber as a preemptive measure. AV node block, the best thing is to use is dual chamber. And cardioinhibitory symptoms, or syncope, sorry, you use dual chamber pacemaker plus specific algorithm. And heart failure, where signs and symptoms with increased QRS duration more than 120 and ejection fraction less than 35 is biventricular pacemaker. That has basically concluded today's session. And next is going to be a quiz made of 2 questions basically. Ready? So this is the first question. You might read the question and then pause for a second and come up with an answer. So the first question is, 81 years old male, does not take any medications, normally fit and well, comes to the GP complaining of dizziness and lightheadedness, which is basically lightheadedness. The GP decides to do 24-hour tape. 24-hour tape shows bradycardia, heart rate ranging around 40s, with a bundle branch block morphology and a QRS duration of 147 milliseconds. Which of the following is the best option? Number 1, single chamber atrial lead. Number 2, dual chamber pacemaker. Number 3, get an echo. Number 4, biventricular pacemaker with an atrial lead. So the answer for this question is get an echo. Why did we say get an echo instead of saying biventricular pacemaker plus atrial lead? Because first of all, this patient has got symptomatic bradycardia, so he's definitely going to get a pacemaker. The question is it going to be dual chamber pacemaker if it's only symptomatic bradycardia, or it's going to be biventricular pacemaker plus atrial lead? And the thing which is going to determine all of this is the echo and ejection fraction in the echo. If it's less than 35, then it fits the criteria that we spoke about earlier, which is ejection fraction less than 35, QRS duration more than 120, and basically signs and symptoms of heart failure. That indicates that the patient is going for a biventricular pacemaker and atrial lead. However, if the echo did not show low ejection fraction, let's say it shows an ejection fraction of 45 or something, that means that the patient has no indication for biventricular pacemaker and he's going to go and get a dual chamber. The next question is, a patient on 7.5 milligrams of bisoprolol had a single ECG showing Mobitz type 2. Otherwise, all the other ECGs are completely normal, and all the OBS-wise, he's in normal sinus rhythm, ranging around 60 or so. What is the next step? Dual chamber pacemaker, get an echo, biventricular pacemaker, or withhold the bisoprolol? The answer is clearly and obviously is going to be withhold the bisoprolol for a little bit, because this is a reversible cause. And he's only had one episode of Mobitz type 2, which is completely asymptomatic. So withhold the bisoprolol and observe and see how things go from there. Thank you so much, and hopefully this has been a useful presentation for you.